Our next speaker, Dr. Ushma Wadia, is from Perth Children's Hospital and the Kids Research Institute of Australia, and is going to be talking to us about learnings from the monoclonal antibody program and early insights from the maternal vaccination program. So, Dr. Wadia, thank you.
So thank you very much for having me today present on our experience of the RSV immunization program, learnings from 2024 and early insights into 2025. But before I start, I'd like to acknowledge that the traditional owners of the land on which we're meeting today, the Kaurna people. I'd also like to pay my respects to elders past and present and extend that respect to Aboriginal and Torres Strait Islander people that are in the audience today, both here and online. I come from Noongar Whadjuk Budja, and I'm very grateful that I get to work on this beautiful lands. Prevention of RSV, as Hannah has said, is especially important for First Nations children because they are 2 to 4 times higher risk for RSV infection, and we now have prevention products that can reduce this risk for our First Nations children. So the outline of my talk is going to be about 2024 program coverage, program impact, nirsevimab effectiveness both at a state and national level, and then talking about safety. These are important factors in terms of propagating ongoing immunization programs at a national level, and then provide some early insights into the 2025 program. So in 2024, just to set the scene, maternal vaccination was registered, but only available on the private market. So I'm only going to talk about the monoclonal antibody, which is a long-acting monoclonal antibody against RSV, nirsevimab or Beyfortus. In WA and Queensland, we had a comprehensive program which was targeted to infants for prevention of RSV infection. In other states, there was risk-based approaches. So in Western Australia, last year we were the first state in Australia to announce our comprehensive nirsevimab program for neonates and infants entering their first RSV season and a select group of children up to 19 months who are at increased risk of severe RSV infection. The program was announced on 5th of March. For our catch-up cohort, these are children that were born after 1st of October 2023, and the high-risk group, children entering their second RSV season, that program commenced on 1st of April. A month later, we commenced our maternity or newborn program. The program ended on 30th of September, but continued in our northern parts of the state because of ongoing RSV activity. So nirsevimab in 2024 for WA infants was a single dose given to infants born from 1st of May to 30th of September 2024, year 1 cohort. Infants born between 1st of October 2023 to 30th of April 2024, this is our catch-up cohort. Aboriginal infants born from 1st of October 2022, so these are kids, Aboriginal children entering the second year RSV season, regardless of whether they have risk factors or not, and medically at-risk children. So in terms of coverage, we had more than 1,000 providers providing immunizations, and we delivered 24,000 doses across the season. Pleasingly, the birth cohort, the coverage was 79%. And in our year 1 catch-up cohort, so these are children that were born from 1st of October 2023 to 1st of May 2024, when the newborn cohort started, 65% coverage. Once again, pleasingly, in the First Nations in year 1 cohort, it was 61.1%. Not so much for our second year cohort, but the denominator is probably unknown for especially the medical risk group. The doses were delivered by GPs, maternity hospitals, some hospitals, child health nurses, and other, like the operational medical services as well. But I'll allude you to general practices in primary care delivering 37.9% of the doses. And this afternoon at the RSV session 2A, we heard that in some states that is an issue in terms of engaging general practitioners to deliver nirsevimab to the catch-up cohort once the newborns leave the hospital if they haven't been immunized. I show this graph because it shows that for our RSV season in 2024, the epi peak was epi week 21 to 38 is when we had the RSV season. And the blue bar shows the doses that were delivered. So before our RSV season, we had delivered a lot of doses, and that continued throughout our RSV season. In the end, 71% of our eligible year 1 infant cohort were immunized, and we achieved high uptake, particularly in the birth cohort. I'm just going to switch gears a bit and just talk about 2 surveillance programs that exist, one state-based and one national, which I'll allude to in the subsequent slides in terms of effectiveness. So we set up Revive once the announcement was made, utilizing established surveillance programs that already were in place to look at COVID, influenza, and set up the Revive study, which looked at immunization effectiveness against RSV, acute respiratory infection hospitalization. It included 3 hospitals: Perth Children's Hospital, Joondalup Health Campus, and Fiona Stanley Hospital in Western Australia. The PEDS Flucan Network, as you heard from the talk this afternoon, if you attended the RSV session, is a national hospital-based surveillance program for lab-proven RSV undertaken by the Flucan group and the PEDS network. So it consists of 23 adult and pediatric states in Australia, and is across all states in Australia. So I'm going to talk about the Revive study. This is I'll present the key findings of the Revive study, the first Australian study, and to our knowledge, the first Southern Hemisphere study to report real-world evidence on nirsevimab effectiveness. As I said, it was quickly set up to look at surveillance of nirsevimab effectiveness. And this is a multi-center, prospective, case-control observational study conducted at 3 hospitals. Perth Children's Hospital is our sole pediatric tertiary center with an ICU, and Fiona Stanley Hospital and Joondalup Health Campus are 2 of our larger metropolitan hospitals with big pediatric units. The population were children that were eligible for RSV intervention, with cases being those that had RSV positive confirmed ARI hospitalization, and controls were those that had negative testing, but we selected set controls per week per site. So we've published, and what it showed, so this publication was data from April 2024 to October 2024, because our desire was to get the effectiveness data out in the public space. So what it showed is we achieved 88.2% effectiveness in the combined cohort. This includes both the year 1 and year 2 cohort. When you look at the year 1 cohort by itself, it was 86.4%. This data shows from April 2024 to February 2025, just before the maternal program was started. And what it shows is there is a bit of a decrease in the immunization effectiveness from 88.2% to 81%. And similarly, in the year 1 cohort, there is a decrease to 82.4%, but still good effectiveness of more than 80%, which is similar to what we've seen from the Northern Hemisphere. Oh, okay, sorry. That moved, but this hasn't moved. Just to note that in children, so what we did is we looked at whether effectiveness was different in children less than 6 months and older than 6 months. And what we saw is that 90.3% effectiveness if you're less than 6 months, and similarly 89.9%, it is hard to read, in the older age group. In the Y2 cohort, however, because of the numbers, we weren't unable to show effectiveness, and it was only shown if we grouped it by site. So what about impact? We heard from one of the speakers, Kaya, this afternoon as well, and we've published on the population-based analysis of what the impact of the nirsevimab program was for the infants. And what you can see in the graph is the orange line, and the blue line is 2023 and 2022 data, and the red line, which is much below, is the 2024 data. And there was a 57% reduction in RSV notifications in the children under 1 year of age, and this equated to 500 admissions averted because of the program. At $13,695 per infant hospitalization, this was a saving of $7 million in savings. And what was interesting was that it equated to 1 less hospitalization for every 43 infants that were immunized. We did not see a reduction in children that were more than 1 year of age, supporting that this decrease was because of nirsevimab and not necessarily because of a light RSV season. But importantly, safety needs to be shown so that these immunization products are acceptable to the families. And we also reported on the post-marketing safety surveillance of nirsevimab administered to children through the vaccine safety and surveillance program, which has both active and passive pathways of reporting. And what we found was 24 nirsevimab APHIS, most of which were common minor reactions, and no related serious adverse events were identified. So it's a very safe vaccine, similarly to what has been reported from some of the Northern Hemisphere data. What about 2025? So just to set the scene, in November 2024, the all-year-round maternal RSV program was announced as part of the National Immunization Program. And there was also nirsevimab, which each state and territory funded. So we've got a hybrid program in 2025, the maternal RSV vaccine that's available all year round through the National Immunization Program, and then each state has a nirsevimab funded program. But for the nirsevimab programs across different states and territories, there are differences in terms of whether it's an all-year-round program or a seasonal program. And Hannah has alluded to the importance of when you're thinking about immunization and what product or when is the best time to deliver these immunizations, that becomes important. So ACT, Northern Territory, New South Wales, and Queensland have an all-year-round program, and northern part of WA as well. The rest of the southern states have a seasonal program. Eligibility criteria also differs from state to state. Largely, it's based on the ATAGI recommendations, which I'll show you, but there is variability. For example, in Western Australia, for Aboriginal children entering their second year, it is recommended that they get the immunization. Access is different from state to state, and we heard this today in our talk this afternoon, where access for GPs, for example, in some states where they have to actually then, if a mom presents to the GP practice, they have to then get the immunizations to the office to be able to deliver. They don't have it in their fridge. That was different in Western Australia, where they delivered to primary care providers that wanted the nirsevimab to be involved in the nirsevimab delivery. Those vaccines were available in their fridge to opportunistically give them at the time when they went for their, for example, other immunizations at 2 and 6 months and 4 months. So opportunistic immunization when the contact happened with the health provider. And these are the ATAGI recommendations for the RSV prevention program. So pregnant women from 28 weeks can have a booster for the maternal immunization, and for the RSV, monoclonal antibodies largely, if the infant hasn't been exposed to the maternal immunization, they're eligible for the RSV immunoglobulin if the mom's immunization was less than 2 weeks, no more than 2 weeks, sorry. Young infants who are at increased risk of severe RSV disease, regardless of whether mom has had a maternal immunization or not, and then children with medical risk factors. So this is data just in terms of where we are at in Western Australia. We've delivered more than 6,000 maternal immunizations, 5,000 nirsevimab doses, of which 600 have been to the newborns. And that's because maternal immunizations coverage is probably about 60% for us in Western Australia. But we alluded to this afternoon as well. What has happened to the catch-up program? So this was some communication that Professor Paul Effler did through the vaccine update, where there is a reduction compared to 2024 in terms of the catch-up cohort. Last year, about the same time, our catch-up coverage was 36%. It's 22% this time. So what that tells us is possibly that opportunistic immunization that happened last year is not happening for the catch-up cohort. Is that because of the maternal program being in place, which is what you're thinking about, but then you need to start thinking about making those contacts with those patients when they're there for their 2, 4, 6, and really thinking about whether they've had exposure to maternal vaccine and recommending nirsevimab if that hasn't happened. In terms of safety, we've had 4 adverse events following immunization that has been reported through our vaccine safety and surveillance system. One was a confirmed anaphylaxis, and the others were minor, and one a suspected shoulder injury following vaccination administration. But this individual had other immunizations given at the same time as well. So far, nothing big signals has happened. We are doing data linkage to see other important safety signals that have been said, but we haven't seen anything yet. So in terms of early insights to the effectiveness side of things, when we look at the REVIVE database, we don't have enough to be able to do meaningful analysis at this point in time. So I'm going to present some of the work that Chris Blythe presented in his session today in 2A, the PEDS RSV dataset results. Once again, similar to REVIVE, its objective is to describe epidemiology of RSV in Australia, explore risk factors, but also estimate use and effectiveness of RSV prevention product. Once again, it's similarly set up as REVIVE, or we actually set up REVIVE similarly to other RSV flu-can study, and the population is very similar as well. This just shows the trend of RSV within the PEDS RSV flu-can dataset, where it shows that in 2024, Queensland and New South Wales had an earlier RSV season compared to what Western Australia and Southern Australia had. So when we're looking at the immunization effectives, it's important to take this into consideration because both Queensland and Western Australian programs started about the same time in April, Queensland being an all-year-round program. And then in 2025, the rates are increasing. Once again, New South Wales and Queensland have higher reported rates than other states. And what this shows is the proportion of RSV positive cases by age and jurisdiction in 2024. And as you can see in those states, Western Australia and Queensland, who had an comprehensive infant program, the orange and the yellow are much lower than the other states. What about 2025 compared to 2024? When you just look at that, you'd see that there is reduction in the RSV cases compared to 2024. So 0 to 11 months, it's 44% less. 12 to 23, it's 25% fewer cases compared to 2024. But importantly, in the 2 years and older, it's 34% less. So it's not significantly different. So whether that's an effect of the immunization products, maternal vaccine and mAb that are being rolled out, or is it just too early in the RSV season to make meaningful estimates of what's happening? This slide that was also shown this afternoon, courtesy of Chris Blythe, essentially what this shows is we included from the PIDS fluke and RSV data set both WA and Queensland, and then looking at effectiveness. And what it shows is estimates that were very similar to what was in the Revive with 80.9 and 90.5%. So what are the key learnings and insights? The WA mAb program was highly impactful. There was high uptake, particularly in the birth cohort. We demonstrated effectiveness against RSV-associated hospitalization. There was significant impact on RSV-associated hospitalization with 500 hospitalizations averted. But importantly, it was acceptable to community because we got high coverage, and also immunization providers, as we saw, because primary care providers delivered 30%, and birthing hospitals, midwives, delivered another 30% of the immunizations. Successful RSV, maternal vaccine, and monoclonal antibody immunization programs will have a significant impact on infant health in 2025. And achieving high coverage of maternal vaccine and immunization of high-risk children may be challenging. A coordinated approach between jurisdictions, health providers, and hospitals with clear communication to families is required. We can see a little bit of that effect with the reduction in our catch-up cohort this year. And continuing efforts to increase public and healthcare provider awareness are needed to maintain high vaccination uptake rates. And we need comprehensive safety and immunization effectiveness programs to demonstrate these benefits. Lots and lots and lots of people to thank for the work that I've presented. A lot of the slides have been provided by those that are on this slide, including Peter's slides that I have used, Chrissy's slides that I've used, Paul Effler's slides that I have used. I thought I'd just put that. Some might not be aware, but for next year, our RSV mAb program has been announced for 2026. And that's the end of my talk.
Thanks very much for an amazing presentation. It's clear our colleagues in WA are really leading the way here in so many ways, and so it's fantastic to see so much great data. We've got time probably for 1 or 2 questions in the room, if anybody has any. I know it's probably tough with the mains just arriving, but if there are any questions in the room, we probably have time for a few.
Thanks, Ushma. Phil Britton. I'm going to ask the elephant in the room question, which is, if I think I saw it correctly, at least in the papers, the investment was $11 million.
Yep.
And the estimated saving, I understand it's estimated, I understand its direct costs, is $7 million.
Yep.
So I'm the bean counter in Treasury in WA,
yep.
And I'm thinking you've cost me $4 million, and what has come out of that? Can you argue for the cost effectiveness of this program?
I will allude to the indirect costs that we haven't measured. And this morning, Mark Jeet very nicely alluded to the externalities of immunization programs that we have to take into account, the benefits of that. And also Hannah showed that pyramid where we're really looking at the iceberg. We're looking at the hospitalizations, the severe outcomes, not measuring what's happening at primary care level, what's happening at the community level, and importantly, what's happening at the family level. So we haven't costed the impacts that RSV hospitalization aversion would have on the family, the days that they can go to work rather than having to miss work, the days that they can attend daycare rather than having to miss daycare because of the illness, and also what that impact has had to primary care. That's something that needs to be measured. So yes, it was $7.6 million that we have saved, but we haven't added that extra costs and the indirect and externalities costs. Does that answer your question? Is the treasurer impressed? No. I need Helen Marshall to be able to do the talking, or Peter Richmond.
I'll just make a brief comment. That estimate is the minimum estimate. If you compare the number of hospitalisations that you would expect looking at the number of admissions in children over 12 months of age, there'd be an additional 100 hospitalisations prevented. So we're getting close to sort of actually covering the overall costs, particularly if we look at things that are very important to politicians like ambulance ramping, waiting times in emergency department, and parents getting stuck in ED overnight because there's no beds in the hospital because they're full of RSV. So they're the other benefits that actually politicians listen to. So particularly in WA, where we've had some unfortunate experiences in overcrowded EDs.
All right, please join me in thanking Ushma Wadia for a great talk.